A number of genes have now been identified as contributors to the pathogenesis of PCOS, but all this together counts to less than 10%, explains less than 10% of the heritability of PCOS. It's otherwise having an autosomal dominant inheritance but variable penetrance. This is why all members in a family do not have PCOS. Now, depending on the genetic and some of the epigenetic findings, some guidelines have divided PCOS into different clusters, the reproductive group, the metabolic group, but the majority belong to the intermediate group having features of both of these. Now, coming back to the tale of our two sisters, so after having documented oligomenorrhea in them, the next clinical findings that we need to document is the presence of hirsutism. So hirsutism, as we all know, we objectified it using the modified Ferryman-Galbraith score. But the recent guidelines, although we use a cutoff of around 6 for most patients, but as per 2023, the cutoff should vary as per ethnicity and also the age of the patient, anything between 3 to 6, depending on the ethnicity and age, the different cutoffs we have proposed. But of course, this score has many fallacies, like it does not account for how patient important it is, it could miss some of the important areas, it's sort of subjective. And most of our patients would have undergone some form of cosmetic therapy before they come to us, especially if it is on their face. Apart from hirsutism, the other clinical markers that we should at least look for is a female pattern hair loss and acne, both of which, however, are weak predictors of biochemical hyperandrogenism, not so much as hirsutism. And for the female pattern hair loss, two visual scales do exist, Ludwig and the Olsen scale, but again, we do not routinely do this, but they do exist. For acne, however, no typical scoring system is there, but if it is a persistent or refractory or late onset acne, if there are more than 10 lesions on the face, and if they are unresponsive to the usual topical therapy, definitely they require investigation for hyperandrogenism. Now for the obese elder sister, the modified Ferryman-Galbraith score was 4, and for the younger non-obese sister, it was 8. So what about biochemical tests? So biochemical tests to document hyperandrogenemia, it is useful only when clinical signs are unclear or absent. So somebody having overt hirsutism do not really need to undergo biochemical tests unless and until we are thinking about some secondary causes that would contribute to it. So in the last guidelines, they had only mentioned using calculated free testosterone or free androgen index. But we all commonly practice doing total testosterone, and we do not use the formulas to calculate free testosterone. This is reality. But the total testosterone again should be by the LCMSMS method, not commonly available. We are doing imbalances. It's still reliable, but the free testosterone immunoassays have a lot of fallacies, and it's not recommended. If we have to do free testosterone, it should be calculated from the total testosterone and SSMG. As we all know, testosterone should be measured for a regularly menstruating females between day 2 to day 5, but if she is having anovulatory cycles, it can be any time. No clear cutoffs exist, but a total testosterone value of more than 55 nanogram per DL or free testo of more than 9 picogram per ml or a free androgen index of more than 4.5 are the usually accepted cutoffs. And there is no role of repeated androgen testing to monitor response to therapy in patients with PCOS. Androstenedione and GRs, they are not routinely to be done, but if the testosterone and free testosterone are not elevated and we are having a strong suspicion, then we need to look at this. Of course, we should not forget about the different differential diagnosis of PCOS, all the endocrine causes of gonadal hyperandrogenism, like any adrenal tumors, ovarian other steroid-related blocks that could contribute. Adrenal hyperandrogenism, again, some forms of congenital adrenal hyperplasia or tumors, and some other peripheral causes of course. And so if a patient, for a patient with PCOS, we do expect a mild to modest elevation in testosterone. If it is more than 200, there should be a suspicion for androgen-producing tumors. And the DRs, again, we expect a modest elevation. If it is more than 700, as we all know, we have to have a suspicion for adrenal tumors. And for somebody who is non-obese, who is young and having a strong family history, having more significant hyperandrogenism, we might be missing out the diagnosis of non-classic CAH. And for such patients, the 17 hydroxyprogesterone levels of more than 2 would constitute